Okay. Want to welcome everyone to Cardiology Grand Rounds. We're very fortunate today to have a guest speaker that many of you know and you're all going to enjoy very much. I have the pleasure of introducing our speaker, who is Dr. Eman Hamad from Temple University. She is the director of the Advanced Heart Failure and Transplant program at Temple, as well as the director of the Cardio-Oncology program there, and the medical director of mechanical circulatory support. She's also the program director for the Heart Failure and Transplant Fellowship. You've got a lot of jobs, though.
I do.
Absolutely. At any rate, we welcome Dr. Hamad. She is a graduate, actually, of Montclair State University in Montclair, New Jersey, with a Bachelor of Science degree in biochemistry. Then went on to medical school at Ross University, followed by internal medicine training at University of Connecticut in Farmington, Connecticut. And then she came to this area to do an advanced heart failure fellowship at Jefferson before her full cardiology fellowship. After completing that fellowship, she went to Montefiore Medical Center, part of Albert Einstein College of Medicine in Bronx, New York, for cardiology fellowship, where she was chief cardiology fellow. Dr. Hamad is board certified in internal medicine, cardiology, and heart failure, and really has done a marvelous job over at Temple with their heart failure program. Many of our fellows, of course, have already rotated with Dr. Hamad. She's been the principal investigator or co-investigator in many clinical trials. She has many peer-reviewed publications and has spoken nationally and internationally. And we're really thrilled to welcome you to Cooper today to enlighten us on advanced heart failure therapies and who, when, and what. So without further ado, welcome, Dr. Hamad. Thank you.
Thank you. Thank you very much for that warm introduction. We're actually extremely happy to have the fellows come and kind of, get some of this, heart failure, advanced heart failure experience. And they really do amazingly well when they come. We love having them.
Great.
Okay, so I will start with, I have no disclosures. Some of the kind of main highlights, I'm going to give you a quick kind of 1-minute introduction to the Temple program and background. Then we'll talk a little bit about heart failure background. We'll talk about who these patients are, what are the therapies that we can offer them, and then when is the appropriate time, and then, why, what does the data show as well. So just quickly, the beginnings of Temple in 1892 was started as a 20-bed hospital, the Samaritan Hospital by Russell Conwell, and really was to provide care for those who really can't get care. And then fast forward 128 years later, tertiary care center with many specialties and certifications. Also, we have a proud history specifically in the world of heart failure and transplant. We were the first transplant center in 1984 in the Delaware Valley, and also one of the few centers that performed heart and lung transplants. We reached our 1,000th transplant in 2009, and of course, we continue. Temple has always also been a leader in the field of MCS. In the 1980s, our chief of cardiothoracic surgery at the time, Dr. Koff, had put together the Philadelphia Heart that you see in the picture here. In addition to that, we participated in the rematch study, which we will be reviewing in this presentation, which really put, VADs on the face of use for advanced therapies. We were also the first VAD center in this area and first DT program as well. And now, fast forward, of course, we've done so far more than 1,300 heart transplants and 350 VADs, heart kidneys. We have a very robust pulmonary hypertension program with about more than 300 PTEs so far, infiltrative cardiomyopathy, cardio-oncology, shock team, and many other expertise in the field of interventional electrophysiology with our VAD patients. And of course, a multidisciplinary team. I mean, it definitely takes a village as far as, advanced therapies, from surgeons, heart failure docs, social workers, data coordination, nutrition, psychology. It's really a whole village to take care of these advanced heart failure patients. So that's kind of, our team and our composition. So talking about heart failure and the scope of the problem, and why do we need to really focus on heart failure? As you all know, heart failure is expected to become more common as population ages, and the numbers are just continuing to rise, expected to be 10 million in the year 2037. As far as prognosis as well, survival after the onset of CHF in these patients from the Framingham data showed 50% mortality for men and women alike after 5 years. So it's a poor prognosis for these heart failure patients. You know, in addition to that, their projected mortality exceeds any other cancers. So pancreatic CA is right here, and patients on optimal medical management are here. So their survival is, their prognosis is poor, and it's something that we need to highlight more to our patients and to ourselves as well. Because if you tell a patient they have cancer, it's like, oh, wow, I have cancer, but heart failure doesn't really kind of, you know, make a dent because they don't realize the prognosis. Even though there's more deaths than heart failure from most forms of cancer combined. And then we have also the problem of morbidity, right? Recurrent admissions. So their survival decreases progressively after each one of these admissions. So, you know, to sum it all up, high prevalence, high incidence, high mortality, and about 1 million hospital admissions a year, and then high cost. So a major public health problem resulting in substantial morbidity and mortality. So, you know, who are these patients, you know, that we want to look into? How do we identify them? And I'm going to actually go through a case that actually came to us from Cooper. Dr. Cotto and Dr. Mazzarelli were key. This is a patient, SB, 44-year-old female with a history of breast cancer, lumpectomy, developed cardiotoxicity, and presumed non-ischemic cardiomyopathy from that. And then she was diagnosed about June of 2020. She didn't have any CAD at the time, and her filling pressures were elevated on presentation, but her cardiac output and index were normal. She was put on low-dose guideline-directed medical therapy because she had low blood pressure at the time. And then she presented again in September to Cooper with abdominal pain, which is one of the key signs that we see when patients have low flow, nausea, vomiting. She wasn't able to tolerate treatment on the floor and was transferred to the unit. And afterwards, you know, right heart cath was obtained, and her filling pressures were elevated as well. However, this time her cardiac output and cardiac index were low as well. So she was started on milrinone, and then developed AFib with RVR at the same time, and you know, a lot of kind of issues with keeping her compensated. She was transferred to us to assess for cardiogenic shock and advanced therapies at the time, and you know, it was extremely appropriate timing because at the time this patient did not have end organ dysfunction, which, as you all know, and we'll talk about as we go, can limit their candidacy. So she did not have that, which was great. Kidneys, liver, everything was fine. And that was really because of the great care that she had received, realizing that she was in cardiogenic shock. And then, you know, she came to us afterwards and she got her HeartMate 3 LVAD in October, and she has been doing fine. And hopefully once she's in remission, about a good 5 years from breast cancer, we'll be evaluating her for a transplant. We actually were I was going to have her come and do an appearance because we brought her to VAD clinic, but she was dehydrated and dizzy. So we're just going to give her some fluids. But I would have loved her to kind of make an appearance. So maybe next time. So kind of going through some of the classifications that we look at, and we'll kind of go back to our patient as we go through some of the slides and touch base on some points. But as you all know, the NHA class is what we use or what have been used since 1994 to assess these patients. And they're important because of most of the clinical trials to assess GDMT or guideline-directed medical therapy are based on NYHA classes. But they're good because they tell us symptoms. However, they don't tell us where our patients are in regards to their disease process. And that's where the staging, the ACC-AHA staging, helps, because we can start looking at patients from stage A when they're at risk for developing heart failure, as opposed to looking at them, you know, when they already develop symptoms at stage C. And then, you know, if you look at the sideline here, these stages also look at mortality. So it helps us look at, you know, what's their survival and take that into consideration. So going up to these patients that are at stage D and their survival is 50% at 1 year, which is, you know, abysmal survival. So taking that into consideration will help us manage these folks. So that's why having the stages really tells us where they are in their disease process. And of course, you know, needing to point the fact that having patients who are optimized on meds and not responding, these are patients that can actually have various stages of advanced heart failure. So they're not all the same. And, we use our Intermax registry profiles to help us with that. So Intermax is a registry that we all submit data to about our VADs and our outcomes, and then they give us a report on a regular basis of how we're doing compared to national, so we know where we should be. And from this registry, we have a profile set that would help us figure out where our patients are as far as how long do they have before they need a device. And you have the Intermaxes from in between 4 to 7, and these are the patients who come in and out of the hospital, not requiring milrinone, not in shock yet, but frequent flyers, and they have some of the signs that they should be assessed. And then we have patients who are stable on inotropes, and that's our Intermax 3. And those are patients who have, weeks to months before they need a device or an intervention. And then we have those who are on milrinone and you're going up on the doses and they're still not doing well. And those are Intermax 2. And those are the folks that we say, okay, they need something within days. So we need to plan. And then cardiogenic shock with Intermax 1 profile, those are the patients who are crashing, burning. They need something now. They need a device now. And these are, the categories really from 1 to 7 are patients that you see on a regular basis in the hospital. So just recognizing the timing. And we'll go through that as we do more of this talk as far as recognizing timing of intervention. So risk stratifying these patients, what are things and elements that we can use in our day-to-day? The risk stratification, this is a risk score that was put together by Donna Mancini at the time when she was at Columbia, and looking at what are the things that we could look at to see if patients have a better survival with transplant and VAD. And, the key categories that were looked at were the MAP, the heart rate, the QRS, VO2, CAD, the ejection fraction, the wedge, and sodium. And with this risk score, they actually repeated it after the era of beta blockers. This was done before, and it was still consistent. So, this score can tell us whether they're high risk, low, or intermediate. And, it works whether they're even after the era of beta blockers. So this is a risk score that we use. The Seattle Heart Failure Score is something that you're all aware of, but this is a nice score because once you put some data in here, it actually tells you what the baseline survival is and what it is after your intervention. So it's a good tool also to help patients realize that if you take your ACEs, your beta blockers, your ICD, what is your survival going to be? What are the changes based on the interventions? So it kind of helps them mentally as well, and it helps them understand their prognosis. One of the things that, we don't do well is really explain to patients their prognosis. In one of our support groups, we usually try and have, heart failure patients and VAD patients as well, and transplants, so they could kind of share the information. One of my VADs said that if I knew that I had a 50% chance of being dead or with a VAD in 5 years, I would have taken better care of myself, of my heart. So, prognosis is key. It really helps. And I don't think as clinicians and providers, we do a good job in kind of helping them understand what their prognosis would be. Another thing that we use is our risk stratification, of course, with VO2, the cardiopulmonary exercise testing. And, this really kind of helps us assess, in this study also by Donna Mancini, patients who had a VO2 less than 14 did worse if they did not get a heart transplant, and those who are 14 and above did the same. So that's why we use that as one of our cutoffs and kind of one of the pieces of the puzzle when we do our evaluation. So we get the VO2 assessment. But with that said, the 6-minute walk, which is an easy test, and there's a multitude of studies and looking at the CPET correlation with the 6-minute walk, and it showed a lot of correlation. So using the 6-minute walk is really a quick, easy, simple, and cheap method to assess how they're doing. And usually, if it's a 6-minute walk of less than 300 to 350, that's kind of an indication for you that maybe they're not doing as well. And you could use that to kind of tailor, are they at the point where they need the next step of treatment? And then this is looking at ejection fraction. So this is a study from Lynn Warner Stevenson, and basically trying to see if these patients who have systolic dysfunction and have class 3-4 symptoms, if we could judge by the EF what their survival without transplant would be. And you can see here that, patients with a 30 to 35% had a survival difference, but Anybody who is below that, 15, 20, less than 30, 25, really there was no difference. So we can't really use the EF and say, oh, their EF is 20, so now, they're at risk and they need to be evaluated, as opposed to those who are at 10 and 30. So I usually say once they're, 30 and below is a good point to kind of get them assessed. In addition to also some of the other risk factors that we will talk about. Other things, this is from the ADHERE registry. So the ADHERE registry looked at about 38,000 patients coming in with acute decompensated heart failure, and they wanted to see what are the high-risk features, and they found that a BUN more than 43, systolic blood pressure less than 115, and a creatinine of more than 2.75 are all high-risk features with a 20% mortality in 1 year, as compared to those who did not have that 2.3%. So those are also some of the things that we look at. And, many of our patients come with these indicators. And unless we put everything together, we're not going to realize that they're at that point where maybe we need to kind of start considering them for an assessment. In addition to that, so renal failure and survival. So most of our patients have chronic renal insufficiency, and you can see that their survival without chronic renal insufficiency, with the recurrent admissions or those with, it makes a big difference. So renal failure is another thing that actually adds to that prognosis. What about intolerance to meds? So this was looking at patients who are intolerant to ACE inhibitors. And you could see basically their survival. So these are patients who are on ACE. These are ACE intolerant, not on inotropes yet. And these are not tolerant to ACE inhibitors and are on inotropes. And look at how the survival changes. So that's one of the things that we do look at. Are they tolerating their heart failure medicines? Are they tolerating GDMP? And why are they not? Is it progressive renal dysfunction? Is it hypotension? And you see that as you manage these patients on a regular basis. In addition to that, another sign that we see is diuretic dose. These patients have an increased diuretic dose requirement. And, this study actually showed that survival decreases with the amount per kilogram that you need of diuretics, with the highest dose being the 4 milligram per kilogram here. And you can see how survival decreases. So, we usually meet these patients and they're on maybe 20 Lasix a day or 40 Lasix a day. And then by the time, they become advanced, their kidneys are not working as well. And you need more and more diuretics to get them to where they need to be. So that dose of diuretic required actually is correlated with a worse prognosis. What about recurrent ICD shocks? Also, data has shown also, this is from the Altitude Survival by Rhythm study, patients that also have VT, VF, and recurrent shocks also have a poor prognosis, 68 3-year survival. And then what about inotropes? So, there's many studies on inotropes, and most of them are small studies. But basically, we know that inotropes is just a Band-Aid, and we can see that their survival, usually it's a 50% survival at 1 year. And we could see that, it does not prolong life. It does not help dysfunction, but it's a Band-Aid. It can actually help us bridge these folks, or bridge them, whether it's to palliative or to the next step of advanced therapy, but it's not a solution. So just putting all this together, what are the signs that we should be looking at to know if a patient is going towards the advanced heart failure stages? Symptoms, 3-4 symptoms, EF of less than 30%, and you want to, of course, combine 2 or 3 of these. If they have those information that we saw from the ADHERE registry, the high BUN, the creatinine, lower creatinine clearance, the systolic blood pressure that is low, recurrent arrhythmias, if they have recurrent hospitalizations, so they're coming in recurrently to the hospital, they're not tolerating their heart failure meds. You have patients that, when you first met, they were on Corig 25, and now they're on 3 because you're just, cutting down because of their blood pressure, their dizziness, their symptoms. Increasing diuretic requirement, they're needing more and more, and their creatinine is going up. If they're candidates for CRT, they're not responding. If you are considering that maybe they're in low flow, maybe I need to add some inotropes on board, then, sometimes by that time you already missed the boat. So, you definitely want to be preemptive and look at the signs before that. Are they starting to show that, signs of cardiac cachexia, the muscle wasting, the fatigue, the tiredness? And then, of course, if they have refractory ischemia with no options for intervention, that's another indication as well. So the timing is key. This is a figure that just shows us how, as NYHA classes, as you're going up the NYHA class, and then you're showing here that their survival goes down with the recurrent hospitalizations. So more hospitalizations, higher NIHA class, and the survival goes down. So, this is the area that they start developing the end organ dysfunction, where kidneys are going up, liver dysfunction from hepatic congestion, their abdomen is low, they're starting to develop, high tumor necrosis factor, which kind of makes them go into that catabolic instead of anabolic phase where they're breaking down muscles. So, all that, this kind of will lead to them missing a window of intervention. So you definitely want to start thinking about things before they end up in this category. This is another going back to the intermax levels that we talked about, where the intermax level of 1 and 2 are the sickest patients because they're in shock, and looking at how they do post VAD. And we could see here that this is the group 1, which is the highest, the level, group 1, which is the sickest patients per se. And we could see that they have the highest length of stay post VAD. And then if you look at their survival, they have 50% survival post a VAD at 3 years. So their prognosis is poorer the sicker they are. And this also is consistent with transplant. So those patients who are intermax 1 are really sick. Crashing and burning, also post-transplant, they don't do well as well. Their survival is low. So the better they are going in, the better they are coming out, and the better their prognosis is. And this is just kind of talking about timing. You have those NYHA 3 patients, 3A, 3B having symptoms. These are the intermax levels. So at this point, you have one problem that you're dealing with, which is really their heart dysfunction. They don't have the end organ dysfunction. This is the window of opportunity. This is where you need to start thinking of assessing them. Once they reach intermax 1, 2, where they're crashing and burning, this is where they have end organ dysfunction, kidney, liver, cachexia, and many times, I can't tell you how many, we miss that window of opportunity. And many of these patients have been on and off milrinone many times, and because they're weaned off, because they think they're doing better now, and then they go back on it. And by the time we get them, they just miss the window of opportunity, which is very unfortunate. So early referral and early thinking of intervention is key, because that window can be missed. So, ideally, it's nice to have that thought process that, maybe we get them assessed because they have 1 or 2 or 3 or 4 of those categories that we discussed, the risk factors, have them assessed, maybe do a VO2, a right heart cath, and see what they're, where they are as far as their disease process, and then kind of have them, go back to the referring docs, and maybe we'll say come back in 6 months or a year, because you're not at that level yet, but at least they're plugged in, and we know what their risk factors are, and we know what their red flags are, so they could be quickly assessed at the time that they need the advanced therapies. In addition to that, it's very important to take into consideration that patients need time to think about things. Most of the patients that we see, they come and they don't really realize how advanced their heart failure is, and then we're telling them you need a heart pump and you need a transplant, and then in a short period of time they have a heart pump, or they're on a list for transplant. So you really need, if you walk in their shoes, there's a lot of things that have to be thought about. My income, my house, my kids, my job. So a lot of times they say no because they need time to think and change how things are in their life. And so giving them enough time to kind of go through things is really critical. In addition, some of them have, smoking, so they need a 6-month window for transplant. Some of them have weight problems. They need to lose weight for transplant, and, a lot of other things, finances. So the earlier we talk to them about what the next steps can look like, the better it is for them. So this is a study also from one of the device companies looking at asking patients, would you have wanted a device based on what life expectancy you have? So, we could see that patients here who are told that they have a life expectancy of less than 1 month, their response was definitely want it. So the lower the prognosis, the poorer the prognosis, the more definitely, yes, I want a heart therapies. And then we could see as we go down the line, as far as the length of life expectancy, the answers as far as wanting advanced therapies, changed. But still, knowing the prognosis is key in having patients want to go to the next step. This is looking at, the time of discussing advanced therapies with patients, and this is specifically for VAD. And basically here in this study, 33% of patients who got an LVAD got it after 1 week of hearing about it. 56% a month and 89% less than a year. So, if we look at this number here, it's about 80-something% of patients get a VAD within a month of hearing about it, which is really not enough time to, get your life together and understand everything about, just having a heart pump. So the more time we give them as far as knowing what advanced therapies are and knowing that, there's a potential for them needing them, it just helps them have the idea sink in and be more acceptable to them. Early shared decision-making is the key, because you really don't want difficult discussions to be difficult decisions. You're going to die, or you need a heart transplant. You're going to die, or you need a heart pump, tomorrow. So having these discussions early on is extremely helpful for the patient and the medical team as well. So what do we have to offer, and what does the data show? As you know, we optimize with heart failure medications, and of course now we have more and more of these coming on, which is really great. I think the past couple of years have been great for the world of heart failure, and I think we'll see a lot more to come. As far as devices, IV pacing, recently the cardiac contractility modulation also is something that we have been starting to use. But once, they reach where they're not responding to anything and you kind of cross over to the advanced therapy realm, and of course, always consider palliative care, because that's helpful before they go into that realm. They're on inotropes, which could be palliative and hospice, or bridge to, VAD and heart transplant. So the current indications, so why would we put a heart pump in patients? And as you guys know, there's bridge to transplant, so they're waiting on the transplant list, or it could be they're not candidates for transplant and they're getting it as destination, and basically it will be their life support. And, other things, post-cardiotomy, those who fail to come off bypass, and, some patients need it bridge to recovery if they have a myocarditis and they're not recovering in a timely fashion, or bridge to decision. They're smokers, or they have, weight loss and things like that, so they need to work on things to meet criteria for transplantation. And this is just kind of a quick look at some of the short-term devices that we use. Some of which you guys are very familiar with, but, we bridge them with short-term devices, whether it's right-sided or left-sided, impellas or tandems, and then, of course, ECMO, whether central or peripheral, to kind of see if their end organ dysfunction improves, whether it's kidney or congestive hepatopathy, mental status, to see if they are actually candidates for long-term, whether it's a transplant or a heart pump. And some of the main pumps that kind of going through them, as you know, we have the first generation pumps that we used to use before. This is the HeartMate XVE, and I'm lucky that I have one of these. But this is what it looks like. It's heavy, it's bulky, and it caused a lot of problems. And within a year or a year and a half, it needs to be exchanged because of all the complications from thrombus and infection, because it used a big pocket for it. And it was pulsatile. And afterwards, of course, they moved away from the world of pulsatility, and we came up with the HeartMate 2, which is right here, and it's kind of a much smaller pump. And it had an axial rotor, which you could see here, which went in an axial fashion. Much better risk profile than the XVE, which was a pulsatile pump. And then afterwards, we came up with the third generation pumps, and that's the HeartMate 3, which I have here in the HeartWare. Those are the current ones in that category. And currently, the most pump that we currently use is the HeartMate 3, and we'll talk more about that, but it has the best risk profile so far. And then the Syncardia total artificial heart, which you can see here, is really it's a pulsatile pump that actually replaces the LV and the RV. So we use it for patients who really have very bad LV-RV failure, and we can't use two LVADs for. So we've used it about 2 or 3 times, but we only reach out to it when we need to. The main pump that we use currently is, because of the risk profile that we will go through, is the HeartMate 3. It is also a non-pulsatile pump. However, it does have an artificial pulse to it where it slows and speeds. The rotor slows and speeds a little bit to give some washout. And that's kind of part of why it has a better risk profile, I think. And this is kind of a standard and just kind of a quick review how like all VADs kind of function. You have two batteries as a backup. You have the always there's a cable coming out of the abdomen, which is connected to a controller. And this is the newer version of the controller, which actually shows you some of the parameters, but the patients can't change anything here, but they could see what the parameters of their pump are. And this is in general how all kind of pumps look. And then you could see here with the HeartMate 3 and the third generation pumps in general, they actually go into the heart directly, into the apex, so you don't really need a big pocket, which, as we'll go through, kind of has less risk of infection and a better risk profile. And with that said, of course, the gold standard for advanced heart failure still is heart transplantation. But the issue is that we have about 25 to 2,800 hearts a year, but we have about 300,000 advanced heart failure patients that might be candidate for advanced therapies. So if you do the math, it doesn't work out. And that's where heart pumps come in, which are very helpful because they're on the shelf and the numbers just keep on rising. This is data from the rematch trial that I mentioned. There was 11 centers that participated, and we were one of them at the time. And you could see here, 25% survival with medical therapy, and then with this LVAD at the time, which was the XVE, 52%. So that was a big change, and this is what really made a breakthrough in the world of MCS, and we started using these heart pumps. But since then, as we improve our models, this is survival changing with the different clinical trials as we improve our model of LVADs. And this is really the latest data from HeartMate 3. Better survival, less risk of pump replacement and pump thrombus, better hemocompatibility, so less strokes, and also you've seen less GI bleed. So, the idea here is that pumps are getting better. This is the XVE, and you can see pumps are getting smaller. They're working now on transcutaneous charging. They're working on, which means you won't need to have a drive line coming out. You could just charge transcutaneously. They're working on that. I think within the next 5 years, we'll have that out, if not before. They're working on making the pumps smaller. They're working on having the ability of transmitting pump interrogations to your iPhone or whatever device, in order for you to be able to track patients without seeing them, tracking them remotely. So a lot of these things, make the pumps, and the reason why they're not currently preferable to transplant will makes them more of a better option. So, currently we have the infection, the stroke, the bleeding, the thrombus, and of course the drive line coming out of the body. So once we kind of eliminate all these or decrease them, which we are in the process of doing that with all these upgraded pumps, I think the option would be at that time, let's implant patients with these smaller, good risk profile pumps, and then those who are not candidates, since we don't have organs on the shelf, they will be the ones who will get a heart transplant. And I think that's where the field is going, which is really great because patients die on the list every day. So where does the MCS community stand, and in general, as far as advanced therapies, how are we doing? This is just an assessment looking at what percent of population is a candidate for advanced therapies or could be. So based on a 2.6% of a population being advanced heart failure, there's about 30 patients per 100,000 population who are advanced heart failure. And how many patients are we reaching currently? About 2 per 100,000 are actually implanted. So 6%. So, and this is looking at where we are in Philadelphia. So based on this prevalence and the 30 per 100,000, this tells you where every state is. So 1 out of the 33, which is Arkansas, Nebraska, no, sorry, here, this is Houston, has the highest. But this is where we stand in our area, 1.6. So by no means is anybody where they need to be as far as the patients who can be candidates for advanced therapies and can have better outcomes, less morbidity, less mortality are we reaching. So I think there's a lot that we can do. We know that heart failure, in conclusion, we know that heart failure is an epidemic that does not get better with time. And patients should know their prognosis early on in order for them to work on making things better for themselves as much as possible. and knowing what their prognosis is, and introducing them to the possibility of down the road, if they need advanced therapies, what needs to be done, so they know that in advance. And this advanced heart failure therapy, advanced heart failure, and the therapies, it's so under recognized. The common indicators that we ran through, as far as the labs, as far as the symptoms, and basic things that we could do, like the 6-minute walk, are indicators that we could do on a regular evaluation of our patients, and realize when is the appropriate time to refer them before they miss that window of opportunity and develop end organ dysfunction. So currently we're reaching only about 10% of the heart failure patients who might benefit from advanced therapies. And I know as a community, we can definitely do better. This is just kind of a quick rundown of the main criteria that we talked about, from lab values to recurrent admissions, not tolerating heart failure MADs, and starting to show those signs of advanced heart failure. And this is just, how to reach us if you needed to reach us. The transfer center usually is the best way, because they would connect you to the heart failure doctor on service. So whether you're going to transfer a patient or just you need to discuss a patient, I think that's the best way. And then, of course, you could always reach me. Feel free to, call me. This is my cell phone. Email me. And then, this is just our transplant and advanced therapy manager, if you ever need questions or anything like that. And with that, I am happy to take questions.
Okay, wow, thank you, Dr. Hamad. That was a wonderful review of a very complicated area. I think everybody benefited. We have some time for questions, so I'm going to open up to everybody. I also want to remind folks on the call that this is a CME program, so there's a document that everybody got. You should fill out your evaluation form so that we can keep this as a CME program, so please do that. So questions for Dr. Hamad? Anybody step forward? Well, while somebody's unmuting. Oh, did you have one, Joanne?
No, well, I don't. It's not so much a question as much as I really appreciate the the beginning of the lecture where you talk a little bit about or actually gave a specific example of when to refer, because I think that as someone who doesn't practice as at a heart failure transplant center, sometimes you're sort of like, I think that's the hardest thing that we struggle with. So, and I think it's becoming more and more obvious, but, oftentimes we see that people don't even recognize that there's these low flow, low output heart failure patients kind of barely existing in the world. So, so it sounds like, we need to get better at maybe referring a little bit earlier. Is that fair?
Yeah. And I think, like, even if it's a consultation as an outpatient, like, this patient has some of these signs and I want to know if they're at that level. And then we could assess them and say, no, come back in a year, or no, come back in 6 months, because, you're almost there, but you're not there yet. And, do the VO2 and see where they're at, or, so definitely, for sure, I think that would be helpful. And it'd be helpful to explain to the patient that where you are, and these are the options, and you might need them a year from now. So lose that weight, stop the smoking, figure out if you have support or not. And if this is something that you would want, if you were to crash and burn, or do you want to not do anything?
So I guess along those lines, my follow-up question would be, we see a ton of heart failure, and oftentimes it's something that we think is potentially reversible. So I will do my best to do everything I possibly can and follow them, but then, sometimes we see patients get sent over to a heart failure center, simply because they're young, right? And, oh, they're young, you should go to a heart failure center. But sometimes there's a chance that they're going to get better. And, I'm just curious, in your opinion, what should we be doing? Because, we have, and I'm not necessarily talking about like stress induced where we think they're going to bounce back fairly quickly, even, tachy induced, things like that, where they typically get better. But I don't know, maybe a good example would be something like a peripartum or a cardiotoxicity from chemo, where sometimes you're not sure and you're following them. Like, for those patients, they're young, they're probably at that point a very good transplant candidate, but who knows, they may be doing well for quite some time, but you feel compelled because of age sometimes. Does that make any sense?
Yeah, it does, because you want to make sure you don't miss the boat on those young ones. But,
Yeah.
Honestly, even for those, like a consultation,
yeah,
will help. And if you felt that, you don't want to consult, but you want to call and discuss a patient, that's fine too.
Yeah.
You can always just kind of say, I just want to discuss this patient, and that's fine.
Yeah, you had to kind of walk the line between freaking them out completely and saying like, "Oh, I'm going to have you do a consultation at a transplant center," and they're like, "What?" And then, but honestly, you should be having all those conversations early.
You should call it advanced heart failure or just heart failure. It's not really transplant or VAD, because we're heart failure specialists. So most of our patients are heart failure. It's really, the 20-25% patients that are, transplant and VAD. So I was just doing a consult with a patient, now is a remote consult, and they were like, oh, well, when my doctor sent me to the transplant center, I got scared. I was like, well, no, we're heart failure first. Transplant is kind of like, end of the line, not, so yeah, but it's a heart failure consult.
I think that's where the concept of shared care really comes in, although that's originally with VADs and things like that. But actually, the broader concept is, which really solve this problem, is that we should probably refer earlier, but the understanding is that main care will be with us.
Exactly.
And you'll just look over our shoulder and say, yep, I agree with what you're doing. Come back and see me in 6 months, like that, right?
Yeah, and that's exactly what I had in my presentation. As far as, we assess them, we do the the VO2, we'll see where they at as far as the trajectory of when, and then we could assess and say, for the most part, it's usually 6 months or a year, and we'll reassess. And then, of course, if there's anything in the interim where they crash and burn, we already have them plugged in the system. We already know what their red flags are, so it's just helpful.
Yeah, I think that really works well, and we should think about that more often, is referring early, but not with the plans that they're going to go for a transplant. The plan is you're going to watch with us as
Exactly. And then especially now with the, remote consultation and everything, a lot of this can be virtual. And, with some of our folks, we've been doing, virtual with the heart doc and the patient. So kind of like zooming in during a clinic visit or something where we could arrange it. And it'd be like a joint visit, just kind of discussing things. And that's really been extremely helpful.
Right. That's terrific. I see that Dr. Cha texted or put in a message. I don't know if he's on the line, but he wanted to know if there's any role for VADs or mechanical circulatory support in patients with end-stage diastolic heart failure.
Yeah, I mean, end-stage diastolic heart failure is difficult as far as, there's no VADs that could help. Currently they are going to try CCM, so cardiac contractility modulation, in that population. There's a study coming out, which I hope will help. So far, the data is good on that. But, as far as, because their problem is really not forward flow. So, VADs are not going to help them. Now, with that said, so our patients who have HOCM and who do have like really end stage, we do evaluate them for transplants. So they get transplanted, those with restrictive cardiomyopathies and things like that. So we do evaluate them for transplant, and we've transplanted a couple of them.
Do you have a specialized interest in HOCM? Is there somebody at Temple that's interested in that per se?
Well, it's part of our infiltrative cardiomyopathy program, and we're adding to it, hopefully soon, a HFpEF program as well. So it's going to kind of be a combination of that. But yeah, we do, and we've had, Dr. Taylor, our surgeon, has operated on a couple of them too.
So while other people are getting their questions together, if they have them, there was a question that came up yesterday. We had our fellows present topics from the recent ACC, and one of the fellows made a very nice presentation regarding the use of sacubitril valsartan versus ramipril in patients with MI, and it didn't pan out as particularly beneficial, although there was a trend. And I said, we should ask Dr. Hamad her opinion. What do you think about that study, and what about sacubitril valsartan? Are we using it too soon, too late? What are your thoughts?
Yeah, I mean, I think for systolic dysfunction, for sure, I think we have enough data for that. And, I think, except for that study, really everything that they tried it on, even like with HFpEF and everything else, so far it's been showing a lot of positivity. So I really see a lot of potential for it, interest. I don't think we're using it enough. I rarely see patients who come from other places who are on Entresto. And I think it's just because it's relatively new. There's that fear. So, and I think we need to kind of start getting on that boat of changing patients from, whatever they're on to Entresto, because, luckily we have other things that we could start adding on as well. So, which is really exciting, because our world of heart failure hasn't had this much activity in a long time. But yeah, I definitely support, and I think we're going to start using it for HFpEF soon too.
Other questions? Anybody have one?
Yeah, Dr. March, like Simon.
Yeah. Oh, hi, Simon. Go ahead.
Thanks for the talk, Dr. Mann.
Oh, thank
Do
you.
you have any insights about COVID patients in the pandemic? It's like a big topic these days, and about have you guys been seeing like very advanced heart failure needing LVADs?
Yeah, you know what? We haven't seen any of our COVID patients really develop COVID and then need. We only had one patient who developed, COVID myocarditis, but recovered afterwards. He was on temporary support at the time, and then he recovered afterwards. But we haven't had a big slew of it. We've seen, some of our active heart failure patients who developed COVID and did not do well. We had a couple of transplants as well, but not patients who from COVID developed heart failure, other than that one patient that had myocarditis who actually recovered.
Other questions? I sort of have a general question for particularly some of the fellows on the line. When we're treating patients with heart failure, I'm talking primarily systolic heart failure, systolic dysfunction. We know to use, of course, the evidence-based beta blockers, ACE inhibitors, graduate up to Entresto, mineralocorticoid antagonists like, spironolactone. But it's never crystal clear what order to add these things, and you can't add them all at the same time because of hypotension typically. So is there a heart failure expert method by which you like to add these medications? Is there any, can you give us some guidance on that?
Usually, I think you just want to, for sure have, the ACE and the ARB or ARNI and the beta blocker. So beta blocker and one of those families on board. And then as far as up titration, I usually go by their heart rate and their blood pressure. So if their heart rate is really high and I need that, or they have anything else like AFib or anything else that needs control, then I focus on the, beta blocker more than I focus on the ACE ARB. But I try and optimize those two before. I definitely add the Aldactone. Aldactone I add as long as their potassium is fine. I don't wait. But as far as adding something like isohydralazine in African American, definitely try and make sure that they're on an optimized dose of the ACE, ARB, ARNI, and beta blocker before I do that. And then as far as adding things like Entresto, as soon as I see these patients, I put them on it. And if I see them in the hospital, I actually start them on it because, why switch? The only time I'm a little cautious with Entresto is if I have somebody who's really, post-shock recovering and really hypotensive, and I don't know how they're going to respond. I usually start with a losartan and then transition them to, but never lisinopril, just because it's going to take me washout and things like that. So I'm shying away a lot from the ACEs and just kind of focusing on ARB so I could transition to Entresto, or just Entresto from the get-go. And then of course down the line, once they're on all of these, Farxiga is another thing that hopefully we'll start using more and more, because I think it's new, but it's definitely underused as well. And I think part of it is because we don't have the guidelines yet, but I know they're coming out in a couple of months, which would also push for more use of Farxiga.
Yeah, absolutely. That's going to completely complicate this again, but in a good way. We have more medicines to think about. Yeah.
Exactly.
Right. Okay. Terrific. Any other question? We have a few minutes if the fellows or anybody have a question. If not, I'm going to bring it to a close. So we'll wait to see if anybody has a question. All right. It sounds like people have had all their questions answered. And of course, we're delighted, with the opportunity to send our fellows to Temple. They always rave when they go there. And we love having you guys teach us as well. So we really appreciate it. So Dr. Hamad, I want to thank you for Cardiology Grand Rounds today. It was fantastic. And we look forward to ongoing collaboration.
Yes, for sure. Thank you very much. And I just want to reemphasize, please reach out to us, whether it's for discussion or you just want to talk about a patient. We're happy to help.
Okay. Thanks again.
Thank
Everybody
you.
have a great day.
Everybody. Have a good day, everybody.
Thank you.
Thanks.